Thank you. It's such a great honor for me to be here and doing this chair, the Ron Harden chair. I see him in all the pictures, and he's also going to play a role in my talk, and I'll talk a little bit more about that later on. So thank you very much for inviting me and allowing me to spend some time here. My talk is on assessment because my specialization is on assessment, and I'm going to take you on a journey that I took myself over the many years that I've been involved in assessment. That leads to a vision on assessment that you may find a little bit strange. And you may wonder at the end, how is this possible? And how could we implement this? Is it implementable in your setting? Anyway, what I'll do is I'll start from educational practice and the research that has been done, because there's been a lot of research done on the issue of assessment in medical education. From that, I will derive some theory on assessment. And then from that theory, I'll move back to educational practice. And then from that educational practice, I'll move back to research again. And then come to some conclusions. Right? So let's look at some of the tools in our educational practice. There are many, 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 many tools. A lot of tools. And many of you probably know this Miller's pyramid, which is a simple model of competence. And we basically have been climbing over the years this pyramid with all kinds of different methods of assessment. All pretty well researched, pretty well validated, so we have a full toolbox. And if we look at these different instruments, we can look at their quality characteristics. And I've listed 5 here, but there are many more. For the sake of time, I will focus only on 3. On issues of reliability, how precise can we measure? On issues of validity, what are we measuring? On issues on education and learning, what is the impact of assessment on learning? And for each of them, I will draw some general conclusions. In terms of validity, education is changing rapidly from an input model of education, so many hours of this particular discipline, so many weeks in this particular rotation, to an output-based model in which we define the outcomes, we define competencies, and we cater the curriculum to those competencies. We also changed from a very teacher-driven program towards more student-centered programs, in which the learner is put at the center, in which there's more self-directed learning instead of teacher-led learning. And if we look at those competencies, those outcomes across the world, you see different outcome systems. And there are many more around the world. But what I find striking is their similarity. Each of these competency frameworks has been developed with a lot of stakeholder input. They haven't been developed overnight. And they have been developed with an eye on the needs of healthcare of the future. And what strikes me is that they are so similar. So there's apparently some consensus for what we should train. Another thing which strikes me is that most of those competencies move beyond knowledge, right? It's about all kinds of skills, complex skills, like professionalism, like communication, like collaboration. Interesting that these kind of skills are so much emphasized. There are good reasons for doing that, because there's good research showing that if things go wrong in actual practice, these kind of skills are involved. I've had a PhD student who looked at hospital complaints in my academic hospital. More than 80% of the complaints had to do with communication. Exactly. There's also research showing that if you do well on the labor market, these kind of skills are involved. And there's also good research showing that if there are problems in the labor market in terms of clinical problems, they could already have been seen in school. So we have a task to train these skills in our curricula. How do you learn these skills? Not in a lecture theater. You learn these skills by experience and getting feedback on it. That's how you learn them. These kind of competencies are typically behavioral. So they typically have to be observed, right? They're also complex. You don't learn them in a single course. You can't have a course, let's say, of a couple of weeks on communication. You have an OSCE, and then you're a good communicator. It doesn't work that way. These kind of competencies are your longitudinal strands throughout a curriculum. So these kind of skills are important. And you need to develop them longitudinally throughout a curriculum, right? Well, if we then start looking at these kind of skills, we need direct observation. We need the top of Miller's pyramid. It needs to be observed in an authentic setting, either an authentic educational setting or a clinical setting. So messages that come from the validity research is that there's no magical bullet. You can't have a single assessment that can do it all. There's no one preferred method. If you want to do a good job, you have to have multiple methods, right? The other thing that we found is that we need both standardized methods and unstandardized methods. If you have a curriculum with only standardized methods, you're missing out on something, and vice versa. You need both. What we found also is that a little bit of quality assurance around test development in standardized assessment has a large impact on the validity of your measures. Peer review, bit of psychometric analysis, some QA around test development and test scoring has a lot of impact on the validity. But what we found with unstandardized assessment in the real setting is that not so much the instruments are important, but the people are important, right? If you are my learner and I've observed you with a patient, we'll sit down and I'll give you feedback. The best form of feedback is asking questions. What were you thinking of? Why were you thinking of? Did you think of this? Did you see the reaction of the patient when you did this? Right? So we start a reflective dialogue. That's the best form of feedback. Feedback is not unidirectional. But the quality with which we interact, the quality of the dialogue, will determine, let's say, the validity, the value of the assessment. Not so much the instrument that I'm using. It's the people. Right. Let's switch to reliability. Suppose if I were to measure your length, and I would do it twice, then I would expect a high correlation between the first measure and the second measure. That's reliability. That's reproducibility. That's precision. And we can express it in a reliability coefficient that ranges from 0 to 1. 1 is perfect reliability, 0 is no reliability at all. They say that for minimum reliability for summative tests is around 0.80, right? Here's a table of reliability studies expressed as a function of testing time so that we can compare reliabilities across different methods, right? And we have multiple choices, short essays, problem-solving test, an oral exam in the old-fashioned British tradition, the long case, the OSCE, the mini-CEX, a video assessment that we recorded encounters in actual practice and scored them afterwards, and finally, incognito standardized patients, which we sent out to doctors' practices. And the doctors didn't know they were being assessed, really. We did this ethically, we got consent, and we told the doctors, you're going to be visited by a simulated patient in the next 6 months. Here's a form, send the form if you think you've detected a simulated patient. And they sent us the forms, but not with the simulated patients. So they were completely undetected. Right. With the reliability of 0.80, what is your conclusion from this table? Yeah, but we need quite some testing time for minimal reliability. Or yet in other words, most of our assessments in actual practice are not so reliable. Yet in other words, you make a lot of false positive and false negative decisions simply based on measurement error. So you have to be very careful with single measures, right? And even with the reliability of 0.80, you make about 20% classification errors, pass-fail classification errors. So this is bad news. And it has been found time and over again. The reason behind it is that our behavior, whatever that we do, whatever that we assess, is highly contextually bound, very context-specific. Therefore, you need a lot of contexts, a lot of items, a lot of cases, a lot of stations. You need a lot of sampling in order to come up with a reliable outcome. But there's also good news in this slide. The good news is that you can't say that more objective methods are more reliable than more subjective methods, right? Actually, many subjective judgments make up a pretty robust picture. Look at the old-fashioned oral exam or the long case. A number of decades ago, these were the preferred clinical examinations. And we left them because they were too subjective. And therefore, Harden proposed the OSCE, the objective, structured clinical examination. So he sought to improve the clinical examination by structuring and objectification. However, with more research, we saw that sampling was more important than standardization or objectification, right? And that is good news, because if we wish to assess complex skills, we need professional judgment. Professional judgment, by definition, is subjective. But by sampling across judges and across contexts, you can do a good job. And we can use this to assess in the top of Miller's pyramid, right? Or yes, a single long case is very unreliable and subjective, but a number of them do a good job. Even the long case does better than the OSCE, right? So we've been bashing our old-fashioned methods for the wrong reasons. Right. So the conclusion really is that acceptable reliability can only be achieved if you have broad sampling. And that no method is inherently better than any other method. Yes, you have a question. Yeah. Yeah. Yeah, yeah. Factually, these are projections. So this has not been a test of 8 hours. This has been a test, I don't know, of 2 hours, and then you can statistically predict what it would be over there. Yeah, I won't go into details. I'll answer to that later on, okay? Afterwards. Right. Objectivity is not the same as reliability. And objective methods can be unreliable, while subjective methods can be reliable. Right? So many subjective judgments provide a pretty robust picture. Okay, we switch to learning. So we dealt with reliability, validity, we now move to learning. Assessment and learning. People always say that assessment drives learning, and that is true. But oftentimes, that learning is not so positive. And assessment drives learning often in a negative way. Our most common approach to assessment is to have a course, an end-of-course assessment. You have to pass it, you move on to the next course. You have to have a good memory, and then you move on. Right? I see a lot of poor learning styles. People regurgitating information on a written test, or simply acting according to the exact checklist in the OSCE because it's been learned by heart. Many students do tricks. So I see a lot of poor learning styles. I also see a lot of reductionism in assessment. There's not much information in assessment. What do? We grade. Grades are the poorest form of feedback you can get. Right? If you would grade me later on a 10-point scale, and you would give me a 7, fine, thank you. What should I do next? Yes, get an 8. But how? Grades are information poor. And this is particularly true for complex skills. If we talk about communication or collaboration, grades kind of are meaningless. And we need more narrative information, qualitative information. That is more meaningful. And I see very little longitudinal elements in assessment, right? It's all modular. We don't look at how people develop over time, how people grow. Our most dominant practice in assessment, I can put that in a caricature. That's this one. Are you familiar with the forget curves in psychology? If you learn something by heart for the occasion, 50% is gone after 1 or 2 weeks. What kind of learning are we promoting with this approach? And should we not change that? And in my view, there should be no assessment without feedback, meaningful feedback. Right? And if it's a standardized test, then you can give scores, quantitative information on where people stand in relation to, for example, the blueprint categories. So there's information, right? We've also learned, particularly for complex skills, that narrative information has a lot more value than quantitative information. And we've also learned that the provision of feedback is no guarantee for feedback. A lot of the feedback is ignored by learners. So you have to scaffold the use of feedback. in some way, so that the students kind of are forced to self-analyze and to use feedback. Feedback follow-up is really important, right? I've observed this, and we came to an action. She's going to structure the consultation the next time a little bit better than she did this time. Okay, I'll see you next week, and we'll pick this up again. And then we need more longitudinal assessment, right? So that, to me, is my messages that I pick up from the vast research that has been done in assessment. Now, I'm going to use this information to theorize a little bit about assessment. To me, the implications are that if we look at the results of validity, we need a multitude of different methods, right? And if we look at the reliability research, we need a lot of combined information. Sampling, sampling, sampling. And for the learning aspect, assessment should provide meaningful information. And that, to me, is the basis for programmatic assessment. And I'll explain programmatic assessment to you. In programmatic assessment, every individual assessment is considered to be but one data point. And a single data point is not really meant for decision making because it's flawed. Very flawed, actually. So in programmatic assessment, pass-fail decisions are removed from individual assessments. The focus is entirely on giving feedback, not pass-failing. And then that data point is optimized for learning. And I myself, I am completely agnostic in relation to method of assessment. I don't care. I care about your justification, your educational justification for using that method in that moment in time and in relationship to the rest of the program. If you do a smart job, you will let your learners verbalize over there, write over there, defend over there, and so on and so forth. Basically, you're transmitting educational messages with your choice of method. In any case, there should be feedback. And then the summative-formative distinction, I'd like to replace by the concept of stakes. What is at stake? And there are low-stake assessments, individual data points, and there are higher-stake assessments. For example, about progression, the pass-fail decision, ultimately. Those are high stakes. And the number of data points should be related to the stakes. So if there's a high-stake decision involved, you need a lot of data. Quite logical. So if there's a single data point, a single assessment, the focus is on feedback and it's low stake. Somewhere throughout the year, for example, we need an intermediate decision. How are you doing as a learner? Which are your strong areas? Which areas need further development? Which areas need further attention? Maybe even remediation. And then ultimately, for example, progression to the next year or graduation is a very high-stake decision, and that is taken on many, many data points, right? The decision-making is done by committees. I'll come back to that later on. It's not a single person making that decision. It's a committee. The committee decision at the end, the high-stake decision, can hardly be a surprise to the learner, right? Because then something has gone wrong in the whole system. Right. So this is the basis of programmatic assessment. You see each individual assessment as a pixel in a picture. And with a single pixel, you can't see the picture. And if you add pixels, then you slowly see the picture. You see it? Slowly, the picture emerges. And once you have a good picture, you can take a decision, right? Okay. So this is the basis of programmatic assessment. It's, the way we aggregate is also differently. Traditionally, we aggregate things within a method, right? So we have an OSCE, and we have a station on abdominal examination, and then a station on history taking, and then on resuscitation, and then we simply average everything to a whole, hold it against a standard, pass, fail, right? But there's not a clear relationship between resuscitation and history taking, yet we simply add them up. In programmatic assessment, we do that differently. We aggregate across skills, for example, across competencies, from different methods. So we combine the information on communication in the OSCE with information on communication from clinical workplace assessments, or with multi-source feedback, right? So this is the basis of programmatic assessment. It might still be a bit abstract to you. So what I'll do, I'll go from theory to practice again, right? And programmatic assessment is now being implemented in quite a few schools around the world. And as usually, there are always innovators who are in the front line, and it will take quite some time, I think, to further develop. But I'll stay close to home, and I'll talk about our graduate entry program in medicine. That's a 4-year program. People come in with a relevant bachelor degree, and they then do 4 years of medicine. On top of that, they do a lot of research, because they also get a Master of Science in clinical research. Basically, the medical training program is 3 years, and the research training is 1 year. It's a classic PBL approach, classic. First year is written problems. Second year, we have real patient problems. They see real patients as a starting point for their learning. And they formulate learning objectives from the real patient encounter. I report that back in the tutorial group. The assessment is assessment in modules. That might be simple multiple choice. That might be essays. Oftentimes, we break up the assessment so that every couple of weeks you get some feedback on the past few weeks. But there's a lot of longitudinal assessment. In the cognitive domain, we use progress testing. Not sure if you've heard of that. But imagine a final examination, comprehensive multiple choice exam, that goes across all disciplines. That test is administered to all the students in the curriculum. We have an intake of 340 students per year. So at the same time, we have some 2,000 students making the same test. And we repeat that every 3 months, different test, right? But 4 times a year, you will get a final examination, and we will monitor your growth, right? And you can monitor your growth in any area. In terms of the behavioral assessments, we use a lot of peer assessment and tutor assessment, right? And we use multi-source feedback a lot, longitudinally. All assessment is informative and low stake. You don't pass or fail, right? And then the portfolio is the central instrument. What the patient chart is to you as clinicians is the learner chart here, the portfolio. And everything is gathered into that portfolio. So this is how it looks like in a schedule, different modules, progress tests. every 3 months, longitudinal assessments as well. And then we have every student is connected to a coach. We call them counselors. I hate that term because counseling means something different, I think. But they're coaches, they're mentors, right? And they regularly see the learner. Coach has access to the portfolio. Every now and then, there's a meeting scheduled. The student self-analyzes, must make a self-analysis. Remember that feedback is not a given thing. Self-directed learning is not a given thing. I've been in PBL nearly 40 years now. The one thing that I've learned is that self-directed learning requires a lot of directing. Through mentoring and coaching, you can do that. So students have to self-analyze, have to plan for the next period, discuss that with their coach, and so on and so forth. At the end of the year, we take a decision, and I'll explain that a little bit further down the road. We pay a lot of attention to feedback. Here's an example of a system that we use, an online system, where the students log in and can look at their longitudinal progress test score, right? And they can see how well they score in relation to the whole cohort. They can do that for their total score, they can do that for their anatomy scores, they can do that for their total basic science score, they can do that for their surgery score, whatever. So we have a complete profile of their knowledge development. We have an elaborate work-based assessment system in where we evaluate the different competencies, and you can have a spider diagram as feedback. We use, in the Netherlands, we use the KenMeds competencies, and they are listed there. And behind each of these competencies, you see the number of data points that are available. We can look at that across time, monitor that across time, click on any dot, and find all the assessment information behind it. One of the most important buttons in the ePortfolio is the button, generate me all the narrative feedback on this learner. And then you get all the narrative information on this learner. You can filter that by competency, but you quickly get an overview on where the learner stands. Coaching is essential. Reflection, self-directed learning requires coaching. The students love it, the coaches love it. And it's essential for this for this approach. Coaches are regular teachers. It's a teaching role, right? A single coach has about 10 students in our case. And the decision-making is by a committee, right? Not by an individual, but by a committee. And here's a dilemma, because the person knowing the student best is the coach. But if you allow the coach to take decisions, the relationship with the learner will change. So be careful. Therefore, the committee is independent, right? Our coach provides a recommendation which may be annotated by the student, but the committee decides, right? Now you might say, isn't that an awful amount of work? No, it's not. Because these committees are really well prepared, because for 95% of the students, there's a no-brain decision, right? Maybe even 98% of the students, there's a no-brain decision. But you deliberate elaborately on a few learners. And then you weigh arguments, and you come to a decision, or maybe even a recommendation. You have to remediate this, or you have to do that, all depending on what the issue is. You might say, isn't that very subjective? Yes, it is. But it's at least a group decision. And also, we take all kinds of procedural measures that will build to the credibility of the decision. The size, for example, of the committee will build to the credibility of the decision taken. The fact that we have previous feedback cycles and an intermediate decision builds to the credibility of the decision here, because that decision cannot be a real surprise to the learner. Right? The fact that you have appeal procedures builds to the credibility of the decision. All these kind of measures are based on approaches to qualitative research. In qualitative research, you have all kinds of strategies, let's say, to fortify what you're doing. And that's being applied to assessment committees. We've been implementing programmatic assessment, I think, in 2012 in the graduate entry program. A couple of years ago, we've been redesigning our clinical rotations, and I've implemented programmatic assessment there. There's a partial implementation in the skills curriculum in the current first 3 years, and we're preparing a full redesign of our first 3 years, starting in 2021, using programmatic assessment. Now move back from educational practice back to research, because in the meantime, there's been quite a few publications on programmatic assessment, and we're researching it. How does it work? Why does it work? Why does it not work? And the things that we find, I think the most important thing is the quality of the implementation. You have to convince quite a lot of people in order to move towards programmatic assessment. If you tell your teachers your role is not to pass or fail your students, what? No, your role is to give information on the learner. You need quite a lot of convincing to do there. It resembles strongly, I think, change from a traditional curriculum to, for example, a PBL curriculum. That requires a shift in mindset. Programmatic assessment requires a similar shift in mindset. And I think this is the most difficult one to achieve. And I'm not even sure it will fit to all cultures. We might have a discussion on that later on. But the same was said about problem-based learning as well. Well, that's functioning in every culture at the moment. Well, the biggest challenge is getting high-quality feedback, because that resides within the teachers, right? And it's difficult to get good feedback in a very busy clinical environment, for example. We do a lot of faculty development. Let's finish up with a couple of conclusions. I think we should stop trying to optimize everything within a single method of assessment. You can't have perfection within the single method of assessment. And I think it's not needed either. You need a more systematic and a more program-level approach, right? The program is the real test, not the test itself. The test is the item in the program. And every assessment may be functional. Every assessment. It all depends on your educational justification for using it. And professional judgment is imperative if we want to assess complex skills. Is that subjective? Yes, it's more subjective. So you have to deal with that subjectivity. You guys are all used in your healthcare practice to make judgments all the time. Is that biased? Yes, it's biased. That's why we have clinical guidelines. That's why we have decision support systems. That's why we have second opinions. But we don't take away your professional judgment, right? And I think we should do the same with with assessment. I think we're so much busy with making things objective that we lose the baby with the bathwater. Subjectivity is dealt with through sampling and through all kinds of procedural measures that build credibility or trustworthiness to the decision making. So to me, the programmatic approach optimizes both the learning function of assessment as well as the decision-making function of assessment. I think you have the best of both worlds. And that is the end of my journey. That's where I stand at the moment. And I would love to have your comments and questions. Thank you very much.
Prof. Cees has kindly agreed to take questions from the floor. So,
yep.
I've always felt that formative assessment, formative feedback is essential, is really important. And yet, students' perception is about the grade, pass or fail.
Yep.
So they will devote more time for summatively assessed aspects and not
Yep.
formative.
The comment is students ignoring feedback, really, and formative feedback.
Yeah.
Because
they don't value formative feedback. They prefer, they get, and they don't care.
Can you blame them?
Well, I can't, but I mean, if they get 7 out of 10, like you mentioned earlier on,
Yeah, it's on.
they don't know why they got 7 out of 10 or why they didn't get 8 out of 10, for example.
But I've had a PhD student from the UK, and his dissertation title was, "Can the summative be formative?" And the short answer to that is no. Because students ignore feedback in a summative system. Because I've passed, who cares? You know? And I think that we're all, and students certainly are, in a very summative mode of learning. But that's the way it is. I mean, if you require researchers to have many publications, researchers will make many publications. If you set the bar for a student to pass the exam, that's what they'll focus on, right? Any individual is a homo economicus. We want to have most effect with the least of effort. So I can't blame them for that. It's how we train them, really. The same, I always compare it with discussions around problem-based learning. Initial discussions were, are students able to do that, to study in an independent way? Well, in the beginning, they're confused because they've been trained in a different way. But they quickly pick up the system. I actually never worry about learners because you have the cream that are cream anyway. Of all the students, they're young, intelligent, adaptive. They'll get it. But it's you, teachers, that I worry much more about. Right? Because we teachers have a fundamental belief system that you have to teach and test in this way. And otherwise it can't be good. But I think all the evidence is saying the opposite. Right? So I can't blame the students for that.
Thank you, Prof. Cees, for informative lecture and way forward to assessment. My question would be a little bit in Malaysian scenario. In 1996, when I was here, the long cases used to be in every school and minimum 2 long cases. Then with the intake number increase and long cases and the assessor, the external examiner not staying longer here, they reduced it to 1 and some done away with it totally and replaced it with the OSCE. Now with the generalizability theory, evidences are produced, G and D coefficients that we have despite, apart from the Cronbach alpha, which tells us, gives us a lot of information that the same, if brought back or revisited, with, say, for example, we still do 1 or 2 cases, but increasing the number of assessors. So your philosophy that we learned that the subjective though, but a group decision. So would it be good thing to have this OSCEs together with long cases? No wonder one long case, but a correlation later on can give us some informed research evidences.
The answer is yes. The answer is yes. I think that Ron Harden has been very effective. I'm even here in this chair. But he's been very effective in pushing the OSCE. And to some extent, the OSCE has become the holy grail of clinical assessment. I'm pushing back a little bit because to me, the OSCE is still simulated, right? It's a simulation. And then the traditional OSCE is a fragmented skills test, testing skills in isolation. Not holistic. Okay, so here's a station with knee examination, right? So 4 minutes on knee examination. In reality, you never see a knee alone. There's always a person connected to it, and there's a story to come along with it, right? And if you test skills in isolation and fragmented, learners will learn them fragmented and in isolation, right? And I think OSCEs we've done away with OSCEs in the clinical years. And we only use work-based assessments now. We only have an OSCE at the end of the 3rd year, which is a readiness for clinical practice test. That's all.
Hello.
Yeah.
I'm Safia. I would like to ask about your assessment data point. You said that every assessment is a data point.
Yeah.
What are those data points? Are they marks? Are they grades? Or are they scales?
There could be scores on a test. They could be, if it's a multiple choice test, you'll get your score, you'll get your blueprint category scores, and how you score in relation to the whole cohort. That's a data point.
But
students
do not know whether they fail or pass.
Sorry?
Students.
No?
How do you make the scores in such a way that students do not know they fail or pass?
Well, you can see where they are. You can see where they are. If they're always in the bottom line, there's a problem. Right?
I suppose the question is, when you have a score, how do you make it not indicative of a pass and failing status? If you give a score.
Well, if you're in the red zone, which I showed you an overview of a graph, if you're in the red zone, you're in the red zone. You're in trouble, right? In our new curriculum, we're going to have what we call anytime assessments. If you have studied anatomy and you think you're ready for an anatomy test, go and find the anatomy test online, score yourself. We don't pass or fail, but the score is indicative of whether you have learned your anatomy or not. At the same time, my coach will see that I have done these assessments and I'm doing well, right? So it's different from passing or failing. I understand your question though, because there's this fundamental belief that we need to pass and fail. All the time.
Yeah, Dr. Ng first, then Dawa.
Hello. I have a little bit of problem in
Only a little bit.
trying to actually understand the concept of programmatic assessment. We in IMU, we have outcome-based learning. So we have a program outcome to achieve, to met. We have a module outcome also, then it can be broken down. Apparently, there is a single test assessment like MCQ, whatever you call it. I would say you would call it a pixel assessment. And you need to build out some kind of picture. So when I look at the title, what the future of programmatic assessment, you're trying to talk to us about this. So I am not very clear what you actually meant by programmatic assessment in terms of the program outcome, in terms of the module outcome, in terms of the single test
Data point.
outcome.
You can have the same assessment system as you have right now, and then turn it into a programmatic assessment format. But then you will have to take away the pass-fail decisions from every individual assessment. You would have to introduce some coaching. You have to focus a little bit more on feedback. And I am very much aware how difficult it is to move towards this model. But I hope, at least, that you have an awareness of some of the things that we do in educational practice with our assessment. And maybe you can think about partial implementations of elements of programmatic assessment, right? For example, increasing the feedback a little bit more. And if you're used to grading, and if you're used to pass-failing, then maybe this formative feedback should be graded as well. I understand how difficult it is to move towards it. But basically, your assessment system can be unaltered.
Right, Prof. Whitney?
Yep. Yep.
Thank you very much. Basically, I come from health sciences. So
Yep.
it's not medical, so we are looking at lab-based, credit-based curriculums. So in program, I guess this summarizes some of the questions why we can't understand it. I can see it in a clinical setting, how that works. But in a curriculum where it's all credit-based and
But we
there's
don't-
pass and fail
yeah.
across, so would that apply, or are you?
Sure.
Yeah, I saw that.
But we don't
with,
give
life
credits to
sciences.
individual assessments. We don't give credits to individual assessments. We give all the credits at the end of the year. Right? So you,
Now, in our context, we've got, for example, the student in one semester has to do 8 modules.
Yeah.
Each module has got 2 credits
I
or
know,
5
I
credits,
know, I
so
know.
it won't
But we
work.
we
You
don't do that.
don't. So if we do, we probably won't do programmatic assessment.
that's right.
Maybe I just can add some perspective because I've heard Case speak on this many times and read up about it and thought about it from IMU's perspective, given the diverse programs from pharmacy, medicine, dentistry, dietetics, and nursing. Actually, what he said just now about the feedback, the less high stakes. So for example, even in the modular format that you have now, if we reduce the number of high stakes and make that as data points to make a judgment on that model, you're already in a programmatic direction. Well, the next thing you will say me is, but Vishna, MQA wants the end of system assessment. But yes, there will be some challenges, but I think the take-home message for us when we try to contextualize is looking at the features of it, which is multiple type points, because different data points from multiple perspectives, and making a judgment collectively based from different perspectives. So we take that, we can adapt some of it lah. Yeah.
Those who are at, like dietetics, or those that has got a whole semester where they do external placement, maybe that we could start with that first before we touch the really credit-based semesters. Something to.
You're
yeah,
right.
thanks.
If you want to start with your workplace part, you can do that there as well. In our case, we've changed our clinical rotations so that students are longer in a single workplace, because we know from research that observational learning is not very effective. And having autonomy, being part of the healthcare team, being responsible for healthcare outcomes, you learn a lot more, right? We also know that if you're transitioning from one workplace to another is not very beneficial for learning. So we created longer clerkships, and we have built-in programmatic assessment. So the learner goes in a workplace by preparing a set of objectives in relation to the outcome systems for this particular rotation. Meets with the coach at the end of the rotation. The same happens for the next rotation, right? So that's how we build programmatic assessment into the clinical rotations.
We can take one more question from Katie.
So, thank you very much. My question is, I agree that what you mentioned about the OSCE is that it's too, it's like just components of information.
There's a microphone coming because
Thank you. I'll start again. Okay, so I agree with what you mentioned just now, is that like an OSCE is too fragmented. So we are just examining like parts of what a student does in a real life situation where you would have a clinical situation, there's a lot more variables. So my question is, for a later semester students, we can actually observe them in clinical situations. But in a earlier semester students, how can we make the testing similar to a real-life situation, so that we're actually in the earlier semesters, we're seeing whether they're able to apply the information.
your question is about how do we do that in
Earlier semesters, yeah. In the
Yeah.
earlier semester students that might not be in a clinical placement yet, how can we assess them to see whether they are able to apply the information to a kind of to a patient, a real-life patient situation?
Well, let me describe our first 3 years. We have a 6-year undergraduate medical program and a 4-year graduate one, but a 6-year undergraduate program. In the first 3 years, they are in their tutorial groups doing problem-based learning. They are in the skills lab where they see simulated patients. Right from the start, in the first week of their training, they have their first simulated patient contact, which is being video recorded on tape and discussed in a group with a tutor later on. And they do that every 6 weeks. So every 6 weeks, they see simulated patients, right? And they have to apply the information from the tutorial group to the simulated patient contact. Actually, in year 3, the problem-based written problems are replaced by real patients. They go to an outpatient clinic, see a real patient, formulate learning objectives, report back to the tutorial group. It means that the students should be prepared to do clinical skills in the 3rd year of their training. So you have the first 2 years to learn your clinical skills. That's how we do that.